media personality, but also acting as the research manager for NIHR grants and Roshni too, and working with the Lancashire and South Cumbria NHS Foundation Trust. So as Naseem said, you will be telling us about the UK experience, and I'm particularly keen to hear about your work in community engagement and patient public involvement. So hopefully you'll touch upon that as well as you talk about your topic today. So welcome. Really keen to hear your talk.
Thank you very much. Thank you, Professor Dave. So hello, everybody. Welcome. And thank you to all our attendees today. I'll start by just saying it's a very different CIMH for myself and the team this year. We're very used to being in another city, being in a hotel, and being face-to-face and getting to meet fantastic speakers and attendees and learning from each other. But we still have a brilliant lineup of speakers, and I'm delighted to be speaking again this year. So Professor Dave has already introduced me, so I'll be speaking kind of in line with the theme of the conference, which is turning the world upside down, and Professor Naseem has given you a brilliant overview and description of all the work in Pakistan. And it may get a little confusing as the project titles are the same. So Professor Naseem talked about Roshni 1 and Roshni 2 in Pakistan, and I'll be doing the same for the UK, but it goes very much in line with the theme of the conference, in which you'll get to have a strong feel of how we've kind of translated research and learning from Pakistan to the UK and vice versa, and the lessons that we've learned from each other and the capacity building that we've done. Next slide, please, Samin. So I'll start off a little bit around kind of giving you a backdrop, and then my plan is to take you through the journey of Roshni. So like Professor Naseem has already talked about some of kind of maternal depression background and the impact of infants. Our team has done kind of over 15 to 20 years of research within this field, and what I'll talk about today is building on that. And as you'll see here, we have a number of publications. In a paper that we've published in 2012, which you can see on the screen there, we screened mums in the 3rd trimester of pregnancy in the UK, and this was British Pakistani mothers. And we found that the weighted prevalence of depression was at 16.8%. And we looked at kind of more marked non-health difficulties, such as housing difficulties, financial difficulties, and marital difficulties. And what came out from that work, again, was around less social support and kind of talk of social isolation. Another cohort study looked at maternal depression and infant growth development. And again, these were done in the northwest of England, and looking at kind of risk factors for poor child growth and development. And building on this work, I'll move on to kind of the work that we've done so far. Next slide, please, Samin. Thank you. So the research found kind of when we talk about postnatal depression and we talk about applying it to ethnic minorities and kind of improving access to British ethnic minorities, we look at the generic risk factors, and we always talk about when we're adapting that the science stays the same, but the presentation, certain cultural factors that come into play is what makes it different and what needs to be addressed when working with ethnic minority populations. And as you can see here, you've got generic risk factors, which, like I mentioned, are in the published work that we've done, which is around marital problems, socioeconomic problems, health issues, and adverse life events. And then our research and kind of our qualitative work over the years, community engagement work, has kind of looked at risk factors that are more specific to South Asian women. And that during kind of, for example, qualitative work, other research projects, they've asked for an emphasis on these factors, which include living with extended families, community pressures, a lack of awareness, a lack of empowerment, and low self-esteem and confidence. So using kind of this knowledge from our earlier work is how we've built on our further work. And I thought, obviously, given the situation that we're in, it would be important to talk about parenting in a pandemic, and some of what has come up in the media more recently around COVID-19 and the disproportionate impact on Black, Asian, minority ethnic groups, including pregnant BAME women. Up to 1 in 5 women will experience mental health problems during or after pregnancy, and we know from work that it's much higher in ethnic minorities, and COVID has shown a much larger light on mental health disparities. There has been a huge surge of reports. The Public Health England report has highlighted the disparities, and there's been a lot of work with from community groups, from NHS England in the UK, A lot of online, you'll have seen, maybe a lot of you who may be active on social media will have seen quite a large push on kind of really highlighting these disparities and the fact that the uncertainty surrounding COVID-19 is likely to cause additional anxiety. And for a group that is already vulnerable, for a group that is already classed as hard to engage, hard to reach, the effects of this pandemic are likely to be long-standing and undeniable. And I think some of what has come up in some of the work that we're involved with, which I'll explain, and I'll explain the roshni adaptations around COVID in a bit more detail later. But myself and Professor Zain are part of a steering group with NHS England in the UK, which is specifically looking at, it's a BAME Northwest working group, and specifically looking at giving a direct response to these disparities that have come up. And I think one of the things that we always talk about in meetings is that the narrative hasn't changed. So the disparities have been there, the inequalities have been there, the difficulties in people accessing care has been there. But I think COVID has given people a bit of an eye-opener in the terms of, for a community that already has such difficulties in engaging, that have difficulties with, for example, trust in services, something like this pandemic is likely to really increase vulnerability and increase the rates of mental health. So we've prepared some of the messages that you see in front of you as part of a public campaign that will be launched very soon. And the idea is to translate these messages into different languages for dissemination across TV, radio, social media channels, within clinics, and sent out to each pregnant mom, postnatal mom, to try and emphasize that services are still open. Some of the issues that we're having in the UK that this group have talked about and that have been highlighted to us through our roshni work as well, is that unfortunately, due to the limited education that's been given to South Asian communities in particular, because of not having enough materials translated during the pandemic, there's been a lot of mums that haven't accessed services when they needed to, for example, with appointments, and have only gone in when it's been kind of at crisis point, which is in line with some of our previous work in mental health. And this time obviously has had higher risk factors for them and their child. So this campaign is around kind of increasing that education. So I'll talk to you a little bit about roshni 1 to start with. So roshni is, like Professor Naseem has already mentioned, it means ray of light, light in Urdu or Hindi. And roshni is a project that built on a PhD project by Dr. Sobia Khan. And Dr. Sobia Khan did her initial PhD project at the University of Manchester, supervised by Professor Karina Lavelle. And she worked with a group of women in Manchester, a group of Pakistani women in Manchester, where she did qualitative work first to understand the depression cycle of Pakistani women. She then worked with Professor Karina Lavelle to develop an intervention called the Positive Health Programme, which I'll explain in a little bit more detail later. Essentially a culturally appropriate group psychosocial intervention that she developed with Professor Lavelle based on the information that she had got from her interviews with these women. And it kind of targeted some of the things that I talked about a little earlier in terms of the low self-esteem, the pressures of living in extended families and so on. And once Dr. Sobia had completed her PhD project and had this manual developed, we then applied to the National Institute for Health Research on the Research for Patient Benefit Programme to complete a small exploratory trial of this manual and its feasibility in this population. So the trial was done in 2012 to 14. Thank you, Samin. And it was basically in Manchester and Lancashire at the time. And this kind of gives you a bit of a feel of what we did at the time, which was a letter from the GP was sent to the women at 6 weeks postnatal. It informed the women about the trial. Alongside this, we did a lot of other recruitment activities, such as being in clinics, working closely with health visitors, GP practices. At the time in the UK, we had a strong presence of Sure Start centres. So that was used quite commonly in terms of, there were children's centres where mums would go for their baby weigh-in, for their baby checks, and that gave the researchers an opportunity to meet mums. So we screened the women on the Edinburgh Postnatal Depression Scale. Anybody that scored 12 or more were then taken to the next stage of assessments, which was a clinical interview for depression. And those women that fulfilled that criteria, which is essentially a research diagnosis for depression, were then randomized into either treatment as usual or the Positive Health Programme. We also did a set of qualitative interviews within the project. Next, please, Samin. Thank you. So we had 94 women randomized to the study. And again, I won't go into too much detail about results, but I'll give you a little feel of, this is the qualitative paper, which is in BSA Women's Health. And in that we explored kind of very similar to a lot of the work that has been talked about with the suicide and self-harm prevention and also the parental mental health work in Pakistan, where we explored kind of the precipitating risk factors of their depressive symptoms. We talked about their experience of the intervention and the impact that it had, and kind of one of the quotes there talks about a woman feeling more relaxed and confident. Earlier I could not speak and even go out of my house. Now I go out with my friends and feel that I can do new things as well. And one of the things that I just want to highlight there is obviously we've seen a lot from the Pakistan, and we've seen some quotes and things. And what's important to remember is even in the UK context, when working with South Asian women, there are a lot of similarities in the factors that are being presented. And I think one of the things because I came on as a research assistant on roshni, and even for me, being South Asian, growing up, being born and brought up in the UK, it was still a bit of an eye-opener for me that we still needed to ask for permission, for example, from family members before a woman was allowed to engage in the intervention. For a lot of women, they didn't tell family members that they were coming to an intervention. For example, it was said that, you know, it's a children's centre that they're going to for their child. So just bearing in mind that it was very important that we factored all of these things in as we were working with the women. Next slide, please. Thank you. So Roshni 1 led us to apply for funding for Roshni 2, which is again funded by the National Institute for Health Research, this time the Health Technology Assessment Programme. Myself, Professor Hussain, and a fantastic team of co-applicants worked incredibly hard to get this application through, and we were funded over £2 million to complete this study across the UK. Next slide, please. So this time we decided to focus it on, because we were looking at clinical and cost effectiveness, we wanted to do it across the UK with a larger sample size. We carried it out in the Northwest, Yorkshire, Midlands, London, and also Scotland for a short while. Again, similar process to Roshni 1. This time we screened on the patient health questionnaire. We did clinical interviews for depression for the assessment stage, and then randomized into treatment as usual and the positive health programme. Next slide, please. So the positive health programme, like I said, is a 12-session group psychological intervention. Some of the changes we've made, again, to ensure that we were catering for this population is providing creche, reimbursement of travel expenses and time, and delivery in 5 languages. This is one of the largest studies of its kind in the UK that we know of that is working in the 5 study languages, which is Gujarati, Hindi, Bengali, Sri Lankan, and Punjabi. Next slide, please. So I won't go too much into the detail of the positive health programme, but I'm happy for people to kind of put questions in or send questions later. Essentially, we were looking at the ABC model. We looked at the vicious circle of depression. We used stories and the ABC model to kind of work in each session to target problem-solving skills, empowerment, low self-esteem, religion, spirituality, exercise, that kind of thing. A large part I think that we need to talk about here is around the training. It was very important that we had training, not just in the intervention, but also in things like, for example, what terminology to use. What wording should we use when we're approaching mums, how to use less stigmatizing words, what would be more appropriate. Instead of saying therapy, is intervention better? Is a problem skills building program better to say? And so we factored a lot of that into our RA training, and we had a lot of kind of specific training around cultural competence and working with this community and what was needed to be able to ensure that our research project wasn't acting as an additional barrier to them having their voice heard. Next slide, please. So like I said, understanding and managing self-esteem, as you saw at the very beginning when I was saying that this is one of the things that came up as an additional factor that women wanted addressing. So we had that as one of the sessions. Next sessions, Lunat. Keeping up with the Chowdhuries, again, a play on keeping up with the Joneses, taken from the UK. So again, kind of that comparison, you know, life's not a rat race, that kind of thing. Exercise and looking good for us on Roshni 2 has worked brilliantly as well. A lot of postnatal mums kind of talk a lot about body image. We've had PTs come in, personal trainers, and deliver sessions remote, with the women, and they've taken that really well. Next, please. Religion and spirituality I've already mentioned briefly, so next I'll try and do more of the PPIE side of things next again. Thank you. So the final session we always try to do is more of a kind of a celebratory session. And the reason for this is that we want to acknowledge that it's a huge deal that women from this community have managed to come out, have managed to engage in 12 weeks of a group intervention. For a lot of women, this is the very first time that they've come out to do something that's classed as a social activity. For a lot of women, these are the first social connections that they've made. And the fact that for a lot of women, when they first come, it's like when we ask them about to talk through a day, for example, they'll say, we're really busy. We don't have time to do anything for ourselves. So the fact that this was their first step in doing something for themselves is a huge achievement, and we want to make sure that that's celebrated. So we usually do a celebratory session. People get dressed up, we give out certificates. As you'll see there's some pictures where we've done them in the park. And obviously mums have consented to us sharing pictures of their children as well. And they usually really enjoy kind of doing interviews for us and really talking about how brilliantly they found the intervention. Next, please. So this is around the current progress. I don't have a lot of time. As always, I am short on time, so I'm just going to go through kind of the numbers, which is a brilliant effort and a lot of commitment from the team to work in different ways. And we've randomized 733 participants to the study, which means that we've screened over 4,000, exact number 4319, and we've approached a lot more women across the centres. So this is for a community that is commonly termed as hard to reach. I think by having the appropriate training in place, by having the adaptations, by making sure that our research team were able to factor in everything that may act as a barrier and work in many different ways to engage family members, community, do sessions in the community. Like, for example, we did Chai with Roshni sessions where we sat down and gave women a chance to just come and have a cup of tea with us. We engaged with community leaders. We did a lot of social media work, which you'll see there, which kind of we've engaged on Instagram, Twitter. We've tried to give mums every opportunity for their voice to be heard by adapting our communications. We've worked with local mayors. We've done radio, TV shows. We've done BBC Asian Network, Islam Channel. Again, across the country, we've tried to ensure a presence of Roshni in as many venues as possible so that this study can be one of the platforms where women have a huge chance to have their voice heard. And obviously, our final groups were randomized just before lockdown, which meant that we did need to make some adaptations during COVID. So as soon as lockdown was initiated and social distancing guidelines were put in place, we moved our intervention to a virtual intervention. And again, I don't have time to talk about that in too much detail, but I think, again, it gives a lot of kind of understanding where a community that we have always said won't even engage with services have engaged in an online intervention delivered on Zoom or Google Meet within their homes and have made it work for themselves. So it goes to show that if you are able to adapt and you're able to change the way that you work, the community will engage with you. So I think I'll just end on saying that there's a lot of work that services need to do to be able to ensure that they are adapting their service to meet the needs of the community, as opposed to the community being asked to adapt themselves to meet this service. Thank you very much.
Thanks, Farah.